Today our topic is thyrotoxicosis or hyperfunctioning of thyroid gland. Thyrotoxicosis is a common condition and Graves' disease is the most common cause of persistent thyrotoxicosis. We review the diagnosis of Graves' disease based on clinical, biochemical and imaging characteristics. We also review the pros and cons modality of management for this condition, antithyroid drugs, radioablations and surgery. Now, thyrotoxicosis has multiple etiology, thereby different treatment options. Hyperthyroidism, probably the most common cause of thyrotoxicosis, is the sustained increase in thyroid hormone biosynthesis by a hyperfunctioning thyroid gland. There can be thyrotoxicosis without hyperfunctioning of the thyroid gland. Examples are release of stored thyroid hormones as in thyroiditis or ingestion of excess thyroid hormones. Now the causes of thyrotoxicosis. The cause of thyrotoxicosis are primary hyperthyroidism, thyrotoxicosis without hyperthyroidism or secondary hyperthyroidism. Now primary hyperthyroidism examples are toxic multinodular goiter, Graves' disease, functional thyroid carcinoma metastasis, solitary toxic adenoma, activating mutation of thyroid hormone receptor, activating mutation of GS alpha subunit, example in McQueen-Albright syndrome, struma ovary, drugs and iodine excess area. Thyrotoxicosis without hyperthyroidism, subacute thyroiditis, silent thyroiditis, ingestion of excess thyroid hormone, other causes of thyroid destruction due to radiation. Now the secondary causes of hyperthyroidism, thyroid stimulating hormone secreting pituitary adenoma, gestational thyrotoxicosis, human chorionic gonadotrophin secreting tumors and resistant to thyroid hormone. Now we can diagnose the cases by simple thyroid test, as we said previous day or yesterday, TSH, FT4 and T3 report. If TSH is low and FT4 is high, then it is a case of primary hyperthyroidism. Now we can do the uptake study. When the cause of thyrotoxicosis is not obvious on clinical examination, an uptake study should be asked, and an uptake scan is added when thyroid nodularity is noted and when toxic multinodular goiter or toxic adenoma is suspected. If the cause of thyrotoxicosis is hyperthyroidism, then the uptake of radioiodine is increased, like in Graves' disease, toxic multinodular goiter. Whereas in condition like thyroiditis, the uptake is close to zero. It is important to make this distinction, as antithyroid drugs and radiation can be used for treatment only in patients with hyperthyroidism. Now the management of hyperthyroidism, symptomatic management in the form of beta adrenergic blockade should be offered to all symptomatic patients with thyrotoxicosis. Generally we used propranolol. It is a non-selective beta blocker, most used in the thyrotoxicosis, usually in the dose of 10 to 40 milligram 3 times or 4 times daily. Other beta blockers used are atenolol and metoprolol. Now, caution should be exercised in patient with airway hyperreactive disease before starting beta blockers. Now, the calcium channel blockers like verapamil, diltiazem can be used in patients in whom beta blockers are contraindicated. Now, the anti-thyroid drugs. This class of drug reduces the production of thyroid hormone by inhibiting iodine oxidations and organification of tyrosine residue in thyroglobulin. In India, methimazole, its precursor, carbimazole, and propylthiouracil are available. Dose of 10 mg of carbimazole is equivalent to 6 mg of methimazole. Carbimazole or methimazole is the preferred agent, while propylthiouracil or PTU, due to concerns about hepatotoxicity, is reserved for special situations like first trimester of pregnancy or thyroid storm. Now, যখন আমরা নন সিলেক্টিভ বিটা ব্লকার এবং অ্যান্টিথাইরয়েড ড্রাগস লাইক কার্বোমাজল, মেথিমাজল অর প্রোপাইলথাইরোসিল ইউজ করি, তারপর আমাদের পেশেন্টকে অ্যাডভাইস দিতে হয় যদি কোনো কারণে গলা ব্যথা বা ইংরেজিতে তাকে শর্ট থ্রোট বলে যদি হয়, তখন একটা কমপ্লিট ব্লাড কাউন্ট করা উচিত। যদি দেখা যায় কমপ্লিট ব্লাড কাউন্টে অ্যাবসোলুট নিউট্রোফিল কাউন্ট লেস দেন 500 or liver transaminase enzymes levels are elevated more than 5-fold, the upper limit of normal are contraindication to initiating anti-thyroid drugs. Now, the other treatment protocol for multinodular goiter or toxic adenoma is radioiodine ablations or go for surgery. Now, in a nutshell, if there is a Graves thyrotoxicosis, it is confirmed by clinical or biochemical test, then go for radioiodine uptake study. If it is increased, then it may be a case of Graves disease or multinodular goiter. If radioiodine uptake is reduced, then it is a case of thyroiditis. So, in case of Graves disease, আমরা নন সিলেক্টিভ বিটা ব্লকার প্রোপানল ডোজ 10 to 40 mg per day in 3 or 4 doses to be given, এবং আমরা কার্বিমাজল, মেথিমাজল এবং প্রোপাইলথাইরোসিল ইউজ করি। প্রোপাইলথাইরোসিলের হেপাটোটক্সিসিটির জন্য এটা স্পেশাল সিচুয়েশন, যেমন প্রেগনেন্সি উইথ হাইপারথাইরয়েডিজম এবং ফার্স্ট ট্রাইমেস্টারে ইউজ করা হয়।